So we had a 56-year-old female who presented to your clinic. She comes in with a chief complaint of decreased vision out of her left eye for the past 6 months. No issues with the right eye reported. Past medical history includes hypertension that's well controlled, kidney disease, and gout. Here are her meds, nothing too relevant to the ophthalmology world. And visual acuity in her right eye is 20/20, but visual acuity in the left eye 21/25. Normal intraocular pressures, and then here we go to the first colored fundus photo. This is the right eye and not the eye that she has issues in.
Okay, so color fundus photo, the right eye, the media appears clear. The vasculature or the vessels appear normal. The optic nerve looks, say, pink, sharp edges, maybe slightly obscured inferiorly there, but appears flat. And then the fovea looks also dry, normal, no heme.
Yep, good. And then here's the left eye. Obviously, this is the eye where she had the visual complaints, the decreased visual acuity.
Okay. So fundus photo of the left eye. Media also looks clear. The vessels look a little bit more tortuous on the side. The optic nerve looks pink, sharp, flat, maybe some peripapillary atrophy superiorly there. And then attention's drawn to the fovea. There's this like white sheen covering the fovea. Looks like it might be causing some traction or elevation because you can appreciate some wrinkling of the retina. And then some other like little punctate, not sure if it's exudates, just kind of this more brighter little dots also around the fovea, kind of near the arcades there.
Yep. And then you mentioned like some of the vessels were more tortuous. Which ones? Like the ones up here, superiorly?
Yeah. Superior, a little bit more like corkscrew appearing, and then also inferiorly as well.
And then how about like some of these finer vessels that go into the macula? Like any comment on them?
Now that you mention it, maybe they also look tortuous and then maybe a little bit dragged. Like
I think that one
to the center.
looks straighter to me. Yeah. All right. This is just another type of colored fundus photo, a multicolor of the right eye. I'll just skip over to the next one. So here's that left eye again.
Yep, so kind of highlighting similar findings, but more pronounced on this image, that white sheen overlying the macula, and then you appreciate the wrinkling of the retina around it some more.
Certainly. Okay, going to the right eye, IR photo.
So the IR photo appears normal in the right eye.
I agree. And the left eye.
So the left eye, so there's some, so this is IR, so some maybe a little bit of hyper autofluorescence in the area where we that's correlated to that white sheen. And then you also
it's infrared.
Oh,
Just autofluorescent. Sorry, go ahead.
you were saying it's infrared, so it wouldn't be hyper autofluorescent.
You say hyper reflectance.
Right, so it'd be hyper reflective area where the sheen was.
Okay. And this is autofluorescence, right eye.
Appears normal.
Yep. And left eye.
Okay, so a little bit of hypoautofluorescence centrally. Maybe some, yeah, so hypoautofluorescence where that sheen was.
Mm-hmm. Yep, agree. Okay, OCT. Do you know which eye this is?
Let's see here. Maybe the right eye, because you can
Yep.
see the optic nerve kind of right there. Mhm.
Yeah, and then looks pretty good. Good foveal contour here. Not a lot of disruption of the layers.
Mhm.
And then the next OCT.
Okay, so let's see the left eye. So you can appreciate some reflective material on top of the retina there. And then the retina itself looks elevated, and then some outer retinal layer looks disruption. Looks like there's a lot of fluid, and then some intraretinal fluid as well. And the foveal contours disrupted. So it looks like maybe some traction on the retina.
Yeah, potentially. But in the vitreous, I don't really see like a PVD or like any sort of like fibrous tissue or tractional component. But yeah, everything you said, correct.
There was somebody wrote a paper a while ago trying to differentiate macular puckers that were idiopathic versus macular puckers that were sort of secondary from retinal tears and detachments, like the PVR. If you go back one slide, but I don't think it really worked. That area on the left where the not forward one, where the macular pucker has those little fibers kind of ridging all the way on the left on the surface, right? Up, yeah, right there. That little bridging area where that was a finding they thought was more associated with retinal tears and PVR. But in this case, I don't believe this patient didn't have a tear. So it doesn't really apply to this one. Everybody's been looking, there's a lot of papers on OCT findings and puckers, and none of them have really been all that helpful. All right, keep going, thanks.
All right, and then this is just another OCT cross section of that left eye.
Mm-hmm. So yeah, kind of highlighting similar things here. You can appreciate a little bit more elevation and traction on the retina. And then you can highlight it as that, I'm assuming is maybe like an epiretinal membrane, that hyperreflective material overlying the retina.
Mm-hmm. And then now we're getting into FA, right eye.
So the right eye appears normal. I don't see any this looks like maybe a later stage.
Mm-hmm.
No leakage, no. Yeah, the time is at like 1 minute. Yeah, it appears normal in the right eye.
It's not completely. I mean, there's some funny looking stuff at the like temporal to the macula.
Yeah, maybe just like trace there.
Yeah,
Close.
maybe
The
some.
vessels are wiggly. I mean, it's okay, and it's not late. And don't you shouldn't say leakage with one image.
Okay.
You gotta wait to see. You wait to see.
Right.
Okay.
You're doing well.
Oh yeah, we did have one more, or we had a few more. So I'll just scatter through that. All right, so first, second, third. So yeah, we can start to see maybe a little bit of leakage there.
Is this person diabetic? I can't remember.
I think you just listed hypertension.
So those are probably little microaneurysms. You can get those with hypertension. About 8%, it's supposedly the Beaver Dam study had about 8% of eyes had something out of whack with them. So it's not super rare.
And then now this is the left eye. We're jumping to the left eye, 11 seconds in. You want me to just kind of scroll through?
Which Heidi, what phase is that? First one. Heidi, are you muted? think we might have lost her.
Sorry, you guys hear me?
Oh, now we can, yeah.
Okay, sorry, I got disconnected for a second.
Which phase is this one?
So this is a early phase. We're at 11 seconds, so maybe Venus phase.
What's the very first thing to fill?
Maybe the choroid, I think.
Well, your arteries are full. So this would be arterial. So you got your arterial fill, and then your laminar, and then your venous. So this is arterial, super early. Mostly looking for an occlusion. This was a really thick pucker, so I hardly ever get fluorescein. So that's why I'm going to bring this one to conference. I said what it was, but the I rarely get fluoresceins. But this was like such a crazy looking macula. You got to worry a little bit about vascular occlusions and other things in here. So I just want to make sure everything's looking okay. So I don't see any arterial occlusions in there, right? Okay, keep going. We might have lost time.
And now progressing, that's a second later. Another second later. Now we're at 34 seconds.
Okay.
We're a minute in.
I bet this patient's diabetic.
Any
Just put it in.
comments?
Yeah. So there's some. Looks like maybe. Do you mind going back and forth a couple of times? And I believe it's staining in that hyperfluorescent area, but I'm not too sure. It looks like it has some fuzzy borders as well.
Mhm.
But
Yeah, I thought it was safe to call it leakage at this point, but I don't know if Dr. Cohen has more expert
So in
opinion.
the book, the leakage is fluorescein going into a fluid-filled space. Staining is fluorescein going into a solid thing like a drusen or a drusen. So, and you know from the OCT that this is cystic already. So you could use that, but also if the borders are blurred like that, it's usually leakage. So this would be leaking.
Got it.
Actually, pooling, I'm sorry, pooling is where it fills the space, but leakage is where it just sort of leaks out. So leakage is where the borders kind of fuzz out and just kind of goes everywhere. So this would be leakage.
Yeah, that's what I was thinking with this photo in particular. All right, so yeah, that's essentially the case. These are the key findings. 56-year-old female, progressive vision loss out of the left eye over a 6-month period. With the DFE colored photos, we saw this cellophane-like membrane overlying the macula with surface wrinkling. OCT showed a hyperreflective membrane on the inner retina, loss of foveal contour, increased retinal thickening, and some cystic edema. And then with that FA, we saw some late capillary leakage at the macula. So what's on the top of your differential?
I'd go with an epiretinal membrane, like a macular pucker, maybe like some fibrosis can look like that.
Mm-hmm.
There's some weird things you could throw in if you want to add to your differential for a macular pucker. Anybody, you could put in the hamartoma if you wanted to, like an RP, retinal RP hamartoma. They look pretty much the same. That's mostly it, I guess.
And then just like maybe vitreomacular traction syndrome, maybe then like retinoschisis or something like that, macular pseudohole I threw up there. But yeah, this one I thought was pretty straightforward, getting at epiretinal membrane or macular pucker. So that's what our patient had. And actually what I found out through my reading is macular pucker and epiretinal membrane are considered synonymous terms. There are other terms used to describe it. Epimacular membrane, surface wrinkling, retinopathy, cellophane maculopathy. These terms are really all synonymous, but I think it's more appropriate to call it pucker when you actually have like distortion and loss of the foveal contour. It just makes more sense in my head not to call it macular pucker if you have a perfectly preserved, retina. So what is it? An ERM, it's avascular fibrocellular tissue that proliferates on and adheres to the internal limiting membrane. It's composed of various different cell types. The main ones that we should probably know, though, for board purposes are the retinal glial cells and RPE cells. Other cell types that have been identified in ERMs include astrocytes, fibrocytes, myofibrocytes, and macrophages.
I always
So
like
it's
the
pretty-
myofibrocytes because they do contract. So that some of them do actually, they have this ability to contract sort of like muscle tissue.
Exactly. In terms of prevalence, it's pretty common as we get older. So it was found in like 20% of people older than 75 years old. It affects men and women equally. Mean age of diagnosis is around 65. And our patient, she was unilateral. Bilaterality occurs in about 10 to 20% of cases. And obviously severity varies a lot from person to person and also varies from one eye to the other. So in terms of pathogenesis, so the majority of ERMs are idiopathic, meaning there's no known identifiable cause, but it is believed that PVDs, posterior vitreous detachments, are a necessary prerequisite to ERM formation. And that's why we only see ERMs in an older population who have had PVDs. There's three kind of main theories for how the ERM forms. So the first theory is that as a PVD forms, it causes these little micro breaks in the internal limiting membrane, and this allows microglial cells in the retina to migrate upward and spread onto the retinal surface where they proliferate and differentiate into fibroglial cells. The second theory is that when a PVD forms, there's actually little clumps of vitreous that adhere to the internal limiting membrane. And these little clumps of vitreous have hyalocytes that are exposed, and they can differentiate into myofibroblasts, which contract and proliferate into the epiretinal membrane. And then kind of the third theory, kind of similar, is just that this process of PVD formation, it allows for like an upregulation of different cellular molecules and cytokines that trigger the formation of the ERM. So this is idiopathic ERMs. Secondary ERMs, there is an identifiable cause. So it's really important anytime you have a patient present with a new epiretinal membrane, you need to do a DFE and a careful sclerally depressed exam looking for potential breaks or tears. Other possible causes are inflammation, retinal vein occlusions, trauma, if they had had previous surgery or not. And with these, with secondary epiretinal membranes, you're more likely to have the membrane composed of macrophages, T and B cells, and RPE cells. And that's just based on the kind of underlying cause secondary to inflammation and tears. So signs and symptoms, pretty straightforward. Obviously, you're looking for a highly reflective kind of epiretinal membrane formation in the macula. As it advances, it can become more opaque and fibrotic. And then you look for wrinkling or stria. And a really good hint, if you're not too sure, is looking at the blood vessels. So I thought this picture did a good job of demonstrating kind of straightening of these little peripapillary vessels. They're kind of just being pulled away because of those tractional forces on them. But you can also have increased tortuosity of blood vessels, and it just all depends on the vector forces on the blood vessels. In terms of symptoms, patients complain of decreased visual acuity, metamorphopsias, blurred vision. They can have monocular diplopia and micropsia as well. But the vast majority of patients with ERMs are actually asymptomatic.
I've had a fun symptom. Sometimes people with new ERMs will see their retinal vessels. And I think it's because they shift a little and it's a change and they look at them and you're used to them being in one place and ignoring them and they see them, which is kind of cool.
Yeah, that is pretty bizarre. In terms of diagnosis, it's mostly a clinical diagnosis based on signs and symptoms and your DFE, but obviously you use more specialized testing to aid you in your diagnosis. Most notably the OCT, where you can see that highly reflective layer kind of sitting on top of the internal limiting membrane. OCT is also good for tracking progression as well as prognosis after surgery. We'll get into that more. And then FA can also be used as an aid, as we talked about, most likely to appreciate some capillary leakage. And I think that's just from like the pulling forces, pulling on these fine little blood vessels from the contractile epiretinal membrane. So there's different grading systems for ERMs. I don't think it's too clinically relevant. Kind of seems more academic, but it's based on the one I found that made the most sense was based on OCT, kind of looking at the different retinal layers. So for grade 1, you could label that as a simple epiretinal membrane. You see kind of the start of this hyperreflective membrane formation, but there's still good foveal preservation, good preservation of the different retinal layers. For grade 2, you start to have some contraction of that ERM with some thickening of the outer nuclear layers. Grade 3, even more contraction, even more thickening of the outer nuclear layer. And then grade 4 is when you have it progresses even more and you have kind of loss of that normal retinal architecture. Dr. Cohen, do you use like a grading system at all, or do you just really just look at the patient's visual acuity and?
Yeah, more vision and symptoms. I've not seen a good grading. I keep waiting for something in the epiretinal membrane literature to kind of pop out to help. And so I look at it all, but I haven't seen very much in there that's super helpful beyond just.
Yeah, it kind of seemed like this was more academic. I was kind of reaching to find a grading system for it. It wasn't even mentioned in BCSE actually.
Yeah, OCTs are so definitive. You see them so clearly on OCT. I would think that we'd be able to look at somebody and say, okay, your vision post-op is going to be better, yours isn't. Or you're going to have a 3-line improvement, you're going to have a 1-line improvement. I've not found that in the literature yet. I keep looking at that.
Okay, so in terms of management, obviously the rate of progression of ERMs varies from person to person. Some can remain stable for years and some can progress very quickly. Patients who are asymptomatic, are not bothered by it, potentially don't need any surgical intervention for it. There is one study that I saw, it was called the Blue Mountain Study. It came out of Australia. Is a population cohort study that involved like 5,000 patients, tracked them over 5 years. They found that 20% progressed, about 26% regressed, and then around 40% remained the same, so pretty stable. But I'm sure if you track that over a longer period of time, you'd see that more would probably progress. And then the OCT we use for staging, we use it for monitoring prognosis. And this was one of the questions that was asked. We look at the ellipsoid zone specifically, since that's kind of representative of our photoreceptive layers and our potential for visual acuity. There are no preventative measures for idiopathic ERMs. We can't do anything to prevent floaters or PBDs necessarily. But obviously with secondary epiretinal membranes due to underlying like inflammation or a tear, we can do something about. And then when a ERM or macular pucker, it becomes symptomatic, we obviously want to do surgery for it. The threshold to intervene varies from surgeon to surgeon. You guys were just talking about that moments ago. It sounds like Dr. Cohen, you're a little bit more aggressive. You don't like to wait more than a year. I know Dr. Bowie, Dr. Tordelia, they mentioned 2060. Visual acuity was kind of their threshold to intervene, but obviously has more so to do with how it affects a person's activities of daily living. So the surgery for it is a pars plana vitrectomy plus a membrane peel, plus or minus an internal limiting membrane peel. So not all surgeons peel the ILM along with it, but just the majority of cases I've come across and through my reading, it seems like most surgeons choose to do an ILM peel as well.
That paper you're referencing, I think that's Johnson and Michaels' old paper, isn't it? From the 80s or 90s? That's an old paper.
That sounds familiar, yes.
There's not a lot of good new ones. Like I said, there was that Chinese one with really good vision going in. But that paper, its indications have changed some. In the old days, I mean, we used to peel, when I started, used to peel puckers, you'd take a 20 gauge needle and you'd bend the tip, and that's what you'd use to peel your pucker. You know, if you think of that in proportion to the epiretinal membrane, I always tell people it's like picking up a piece of paper with a pair of pliers. You know, the newer instruments are so nice. But that's one of the best papers, but it's a really old paper.
Mm-hmm. And so most patients who undergo surgery for it, they improve by 3 to 6 months, but some may not experience improvement until 1 to 2 years later, and very low incidence of recurrence after surgical intervention, only about 1%.
I don't know if that's true. I think it's actually higher. I think it's 5 or 10. One of the things supposedly lately, which you'll see in that video, there's some thought that peeling the ILM may reduce the recurrence.
Right, and that's, yeah, I think that's.
I think recurrence without peeling the ILM is actually more like 5 or 10%. A lot of them, I've seen a fair number of recurrence. It's kind of frustrating.
Yeah, I think the thought is if you leave the ILM behind, you're potentially leaving some of those cells that have the ability to differentiate, proliferate again, and contract. So
yes,
I think it makes sense in my head why you would want to do an ILM peel at the same time.
I had been taught a while ago with their lectures, people say it's also scaffolding. That somehow the ILM is a scaffolding for things it's hard for an epiretinal membrane to grow without an ILM to start on.
Mm-hmm.
I've seen that happen though. So it's like funny, it's like it shouldn't happen with those.
Yeah. So here we have a pretty cool video. I'm assuming this is your work, Dr. Cohen.
Yes, yeah, that's my video. So that's my lens.
So he's got his 3 ports here. And let's see.
It's the Oculus surgical made it. I haven't been marketing it. So nonchalant just
So I think we can visualize it at this point because you may have injected triamcinolone that helps stain the epiretinal membrane. It kind of has a more whitish look. So this is peeling the actual ERM.
And I always tell people it's exactly like peeling Scotch tape off of paper or starting a roll of toilet paper. You just kind of grab it and peel it.
And then second phase, injected, I think, methylene blue or a blue dye to stain the internal limiting membrane.
It's really tight in this patient. See how the retina's lifted up? It's kind of unusually tight. scarily scary. I stopped at one point. Everything's not on the video, but like that area where it's kind of white temporally. I tried to peel that and it wouldn't really come very easily, so I didn't. It's the thing with surgery. A lot of times you have to have done it for a while. You kind of get a feel like, oh, that's a little bit too much, or you know.
Okay, and lastly, so this patient followed up a month later. I don't know why her visual acuity decreased in the right eye, but the left eye, it's 20/25, so a dramatic improvement. And we can see the OCT here. A little bit of a rough surface in her retina, but that's to be expected after a membrane peel. But kind of loss of that retinal thickening and cystic edema, it's starting to normalize a bit more.
I think this is interesting. I think one of the reasons this patient did so well, and I've seen this rarely, I think some patients, the epiretinal membrane, some of the vision loss in some patients from an epiretinal membrane is actually the opacity. I think sometimes it's so thick and white that it actually is like a little piece of cardboard over the retina. And when you pull it off, they just see better quickly. Most membranes, it's more the distortion. But I think this one was so thick and white that it was just blocking the vision.
Yeah, that makes sense. And that's it for the case.
Very good. Thanks for doing that. Nice job.
Yeah, of course.
That's a big topic, and you covered it well. I don't know there's much else to cover on it, if you're honest. But that's a lot of what, a lot of ophthalmology, a lot of retina is epiretinal membranes. Very good.